All right. This morning, I'm excited to introduce Dr. Stephen Eubank to the Consortium Colloquium. Dr. Eubank is Deputy Director in the Network System Science and Advanced Computing Division and a professor in the Department of Public Health Sciences at the University of Virginia. And his research interests lie in simulating large-scale realistic systems, computational epidemiology, and network structure and graph theory. And he's previously researched fluid turbulence, nonlinear dynamics and chaos, time series analyses of markets, natural language processing, and simulations of large interaction-based systems. So, a very wide variety of computational approaches being used. As a staff member at Los Alamos National Laboratory, he was a leading role in the development of the traffic microsimulation component of transportation analysis and simulation systems, and developed the epidemiological simulation system projects, which we've called EpiSims, and I think has been discussed in our consortium quite a bit. This work, really pioneered some of the first agent-based simulations of epidemic dynamics using realistic data-driven contact patterns. Since then, he's continued developing advanced technology for the study of realistic systems and also in understanding how disease transmission relates to the structure of underlying contact networks. Finally, he recently has been selected as a Jefferson Science Fellow at the State Department in the Office of International Health and Biodefense, which is a collaborative effort between the U.S. academic community, the U.S. Department of State, and the U.S. Agency for International Development. Those are mouthfuls, designed to advance science, technology, engineering, and medical expertise in areas that impact policy decisions. And I'm not sure if we'll hear any more about that, but we're looking forward to the work he'll do there. In terms of COVID-19 work, his team has collaborated to understand the impact of international travel and screening exercises, advocating for more investment in pandemic modeling, and looking at vaccine prioritization, which I think is what we'll hear about today.
Thank you. That was a comprehensive introduction. But it missed one reason for why I'm giving this talk, which is that I spent most of the 1980s in Austin getting my degree there in Robert Lee Moore Hall. And I really enjoyed my time there, especially Barton Springs and places like that. So let me share the slides and see if everything goes away when I go into, okay. And I also want to point out that you mentioned I was the deputy director of this team, this organization, and Madhav Marathe, who's also on the call, is the director. And I think Chen is also on the call, but in any case, when I get hard questions, I'm going to be handing them over to them because a lot of this work was led and carried out by them. So as you mentioned, I'm going to be talking about the prioritization of allocation of the COVID vaccines. And what we really wanted to look at here, and when I say we, I mean lots of people, all these folks on our team and all the supporting agencies, we really wanted to look at what was, whether this sort of intuitive idea that vaccinating people who have a lot of contacts is a really good strategy, if it's robust against all kinds of problems that you could imagine coming up in a strategy like that. We're celebrating, well, it's not celebrating, we're observing the 100th anniversary roughly of the 1918 flu pandemic, and also the 100th anniversary of models, differential equation kind of models that make mass action assumptions. And a lot of our intuition about interventions has been developed in the framework of those mass action models, where societies are assumed to be uniformly mixing bunches of people, or maybe a few different compartments of people with specified mixing rates. But there's been a lot of progress in the last 20 years, especially on understanding the role of contacts sufficient to transmit disease. And when we look at at a contact network and think about disease transmission across it, there's an obvious heuristic for how to shatter that network into pieces so that it can't support a big outbreak. And that is to vaccinate people who have the most contacts, or possibly to look at the time-weighted contacts that they have and vaccinate people who spend the most time in contact with lots of other people. But there have been challenges in doing research on this problem. So most of the results that are, mathematically provable kinds of things are based on very highly structured random networks sitting in for the contact network, or just simple classes of networks, often poorly specified classes. They've never really been tested with realistic contact networks. They've never really been tested in the context of the kinds of on-again, off-again NPIs that we've seen, non-pharmaceutical interventions that we've seen. And very rarely, I'd say, with the actual logistics of a vaccine supply chain taken into account. There are obvious challenges in implementing a policy like this, and I'll discuss those a little bit more in the conclusions. But I will say that part of the motivation for looking at this again has been the development of contact tracing apps on cell phones. I personally have the Virginia State contact tracing app on my phone. I think a couple 100,000 people downloaded it when it became available. It has never once triggered an alert for me that I was in contact with somebody who had been reported who had a confirmed case. So I have some skepticism about that. But there are also, as everybody's aware now, there's a lot of information about people's contacts, even physical contacts, not just internet contacts, that's available through companies. So these are some of the reasons that we've thought it was a good thing to address. Oh, and I really enjoyed that news summary at the beginning of the colloquium, and I just wanted to point out that I have a vaccine passport from many years ago. This is my yellow fever card. Vaccine passports are no new idea, that's for sure. So let's keep that in mind. Okay, so to spare you the suspense, here are the key findings of our work. We think that you can avert significant, substantial numbers of infections, hospitalizations, and deaths by using network-based strategies for vaccination. In 2 months, just in the state of Virginia, we think you could reduce the number of infections by 56 to 100,000, the number of hospitalizations in the thousands, and the number of deaths by 700 to 900, which is roughly 6 to 8% of what we expect by just following a degree-based vaccination allocation strategy. These strategies significantly outperform age-based and other allocation strategies. They dominate. Even when there's errors in the strategy itself, and I'll talk about what those kind of errors are. But even if you don't have exactly the class of people vaccinated that you would think you would need to, you can realize some of these benefits. So it seems like these strategies would be very important when non-pharmaceutical interventions are being relaxed while you're doing the vaccination, or when vaccines are in short supply, as they are in resource-poor countries. So how do we go about studying this? Well, our approach, like you said in the introduction, I have argued for the use of agent-based models for a long time, partly because of their ability to represent targeted interventions like this. So we used a detailed agent-based model to study the population-level consequences of of decisions made at the individual level, specifically targeting interventions like vaccination in the context of decisions that people might be making about adhering to non-pharmaceutical interventions as well. So we simulate the outcomes in a model that's calibrated with real data on COVID-19 cases. We've been providing weekly briefings to our state Department of Health since last March. So we've been following the data very carefully, especially in Virginia. We model the structural changes in the contact networks that are due to the changing advice about non-pharmaceutical interventions, as well as the changing uptake or adherence to that advice. And we compare the outcomes, these consequences, with age-based and occupation-based prioritizations, because our population has some notion of who are the essential workers. So this kind of an approach you really need to have a lot of the basics there before you can even get around to modeling with this kind of approach. And in our case, the basics were this detailed representation of the Virginia population and the social contact network. So it's still different from many other academic environments that have synthetic populations. This is a causal generative model of contacts that's not based solely on observations like mobile phone data or something like that. So people in our synthetic population are endowed with activities that they need to perform, and they perform those activities in places given the land use patterns in a specific area. So they go, if they're going to work, they go to a place where they could do the kind of work they need to do. If they're going to school, they go to the actual school that serves their local district, things like that. So we call this a digital twin of Virginia. Once you get to a representation that has that much detail in it, you're pretty much required to use high performance computing to simulate what goes on in it. So we have a simulation model called EpiHyper that Chen has been developing for years now, and modifying. We've made significant modifications during the course of COVID. And as I said before, the whole idea of actually being able to implement a network-based prioritization is also enabled by the digital contact tracing apps that are becoming available. So overall, what changed in how we approach this study from the way we do other things? Well, we always have case surveillance to inform the disease parameters of our model for calibration. We have surveillance on non-pharmaceutical interventions and who's adopting them. All these things go into this epidemic simulation. The contact network is always there. And we always measure the population outcomes from the simulation. What's a little different is that instead of just using the demographics of the population to inform the allocation policies, we're using the contact network itself to define structural measures that we think should influence allocation policies as well. So I've said a few words about the digital twin. This is a little more, it's a cartoon that might give you a more concrete feeling for what it is. We've got avatars basically of every person in the population, what they do all day, where they go to do it, who they meet when they're there. And they provide us with a contact network that allows us to say, suppose this particular person identified by their demographics decides to wear a mask, or decides to stay home, or decides to get vaccinated. And it's done in such a way that we don't really have any privacy concerns about the data set. We view this population as a coordinate system, just like a vector space basis coordinate system. If you have new pieces of information, you can find a place in this coordinate system to add on that information. And this organizes it in a way that makes it computable. The disease model we used in our simulations is based on the CDC, I forget what they call it, the consensus CDC model of, I guess, about 1 year ago. It has a lot of states. As you can see, it tracks both the symptomatic, the asymptomatic infections. It has exposure in it, latent periods. It decides whether it's medically attended or not, whether it's a severe case, whether it's hospitalized, ventilated, all these things. And what you see in this picture, there's a, it's basically duplicated. The top half is duplicated on the bottom for vaccinated people. And the whole diagram is replicated for each different age group that we're following. So it's a very fancy compartmental model, but the compartmental model is applied to each person in the synthetic population. Calibration was difficult, but as I said, we've been doing this calibration for situation assessment in Virginia for the whole duration of the outbreak. So we relied on that kind of calibration to initialize this model. In particular, we looked at prior infections based on cumulative confirmed cases up to late December. And we made assumptions about the ascertainment rate and the asymptomatic rate. Then we seeded some cases based on the confirmed cases that we had observed. The seeding is done at the county level, and it follows the age distribution. But I want to remark that that's the extent of the matching that we tried to do with seeding the cases, was get them geographically seeded correctly and seeded by age distribution correctly. When I first met Lauren, she was working on this project that I think was really interesting that I would like to follow up on at some point, where she looked at I forget what you called it exactly, but like the footprints of a previous outbreak and how that changed the immunity profile of a population. I think that would be very important to informing the vaccine modeling. And I'll say a few more words about that in the conclusions. So the disease model was calibrated to the observations that we had. I don't think it took into account new strains, but if there are questions about that, I can get answers for you at the end. So it was with the transmissibility that had been calibrated to the past year's experience. We included non-pharmaceutical interventions that were in place. We just gave them basic overall effects. So we said that people who practice preventive behavior reduce their infectivity by 60%. Generic social distancing, some fraction of the population chooses to reduce their activities, non-essential activities. Virtual learning, home isolation of symptomatic cases. And then we added the possibility that compliance to NPIs will decrease over time, especially as vaccination starts. So this is either due to just general COVID fatigue or behavioral change due to the feeling of being protected by vaccination. And also the likelihood that schools and workplaces, businesses will reopen in the next few months. So I just want to give you the idea that this simulation is situated in a real population with real interventions going on, and we try to get the most likely forecast out of it that we can. So we assume that the NPIs are in place when the simulation starts, which they were, but adherence changes. We considered 3 scenarios. Either they stayed in place, they relaxed slowly over the course of 7 months, or they relaxed quickly by getting to the same place in 5 months. And I'm going to go over the treatments of the different factors in the experiment fairly quickly. We can discuss them later if you're very interested. So here's the parameters of the vaccine rollout. We expected 400 million doses by July, which at the time would have been enough for 200 million people. So we don't take the Johnson & Johnson into account. We assumed that they'd be allocated to all states proportional to population size. We looked at 2 different vaccine distribution schedules, a normal one with 650,000 a month, and a delayed one with half as many per month. We assumed 2 different, actually we assumed the vaccine efficacies that you see here, reduced susceptibility by 90% and disease severity by 50%, which was important for us because we included hospitalization and deaths as metrics in the outcomes. We considered alternative vaccine prioritizations. So a random assignment, an assignment to essential workers first, an assignment to older people, in this case, 50 and above. And then we looked at the network structural prioritizations. So first, take people with a large number of contacts, and we looked at the top quartile in degree. So the top quartile in number of contacts a person has during the day. We also weighted the contacts by the duration that we had assigned to them and allocated vaccines that way. Mostly I'm going to report on just the unweighted number of contacts today. So we allowed for a mix of prioritizations, like a mixed strategy, where most of the vaccines are given to the prioritized people, but some are given to people who are not prioritized, 20% or up to 40%. So that experimental design that I just ran through pretty fast, it's 5 factors. It's 3 or 4 factors in most of them. And it gave a fairly large design for a simulation experiment. So this is where it's really crucial to have the high performance computing, is that you have to run, it's a stochastic simulation. We're doing factorial experiments with a fair number of factors, and we try to do enough replicates to get good statistics on the outcomes. So here we go. Here's the results that I quoted earlier. On the left-hand side, using the metric of infections and just comparing vaccination strategy targeting older people in the green with one targeting high degree people in the yellow, you can see that the high degree vaccination has about twice the effect, more than twice the effect as the older people targeting. And similarly for mortality on the right side, not quite as large an effect, but still substantial and way beyond just statistically significant. Then we looked at the 2 different vaccine distribution schedules. Here, what you're looking at is in orange, the in orange, the current distributions and the slower one and the faster one. On the y-axis are the different strategies, and the degree-based ones are up here at the top, and you'll see that they're all, for any of the distribution schedules, the degree-based ones dominate. I'm sorry, I've gotten confused by trying to read the
Yeah,
sorry, the labels. The right-hand graph is the delayed vaccine distribution schedule. The left-hand one is the normal distribution. So what's happening is that the dominance is maintained. The picture is compressed a little bit. You can tell by the x-axis. The reduction in infections is lesser, but it's still dominated by the degree-based vaccinations. It works when you don't know the degrees of the people exactly. So this is the one that is particularly important for thinking about the feasibility of implementing this. All you have to do is pick, all we designed the allocation strategy around was picking the top quartile of high degree people. But even if you can't do that, you can still get most of the benefits of this strategy. Even if you don't know exactly who's in that quartile, you can do this. If as you're doing the vaccine rollout, the non-pharmaceutical interventions are being relaxed, we still maintain the dominance. So what we're arguing is that the strategy is very robust against all kinds of foreseeable problems. It works for high and low vaccine efficacy. It works for different metrics, morbidity, mortality. It works for problems in implementing the system. It works for slower versus faster vaccine rollouts. It's sort of like a cat in the hat thing. Yeah, I'll eat them anywhere. I'll take this schedule anywhere. I think it's clear why it works. I want to say, though, I have argued in the past that degree is really not the end all and be all of network structure. You can certainly construct networks for which degree is not the optimal vaccination strategy. But it seems as though in realistic social networks, it does exactly what you'd expect it to do. You get direct protection for the vaccinated individual, and you get indirected protection because there are fewer people among their contacts who are infected. So it allows you to get more than one effective prevented infection for each dose of vaccine. It's vaccine sparing intervention because you get both the direct protection and the indirect protection. And the direct protection is large because of all the possible people who could have been infected. If you want a more mathematical way of looking at it, we can consider the eigenvalues, and also on the right the maximal connected cores of the network, and watch how they drop. These are metrics, statistics on the network that are under many plausible assumptions closely related to how fast the disease spreads and how far it will spread. And you can look at the effect of the different strategies as they remove nodes from the network on these statistics, and see in that sense why vaccinating people with high degree works well. So how would you go about implementing these kind of strategies? You can use contact tracing apps. You can do that in a way that preserves privacy. The contact tracing apps that we have now do this anonymized key thing that changes around a lot, but you can create the network without having to share a lot of personal data. You can count interactions instead of just detecting whether you've interacted with a particular person. people don't have to reveal anyone their degree, whatever sort of privacy that might violate. Also, and this is something that we really should have been investigating for a long time, but we haven't. We should be able to identify proxies for degree. So to some extent, say essential workers working in large production facilities are probably going to have high degree. Older citizens with maybe homebound people are going to have lower degree. There are rules of thumb that we might even be able to use as proxies for degree, and we can investigate with these kinds of experiments how well they would work. The study itself obviously has some limitations. I mean, we have 5 factors that we were varying with a few different combinations. It's remarkable to me how robust the results were, even in that design, but you can imagine throwing in a lot of other things into the mix. I think one of the strongest criticisms of the study probably is that when we seeded the population with infections, as I said, we got the right age distribution, the right spatial distribution, but it may be that we didn't, that the people who actually have been infected are the people who have the highest degree. And it would make sense because they're often at highest risk of exposure. And if that's true, then there might not be as many of them left to vaccinate as you might think. So that's something that I'm concerned about in the study. You know, everything else, we've done our very best at estimating the NPIs, the disease parameters, all those things. I don't know, I don't see any places where we could really have done a better job with that. We assume there were no correlations between lots of things that we don't know much about. So for example, between adherence to NPIs and your degree. And some people might argue that very high degree people are also the ones who are least likely to go get a vaccine or to modify their behavior. We assume that there was no efficacy against onward transmission of infected. That could be a problem with the dynamics of the model. It's something that we could investigate if it's warranted. I think though that, especially in a forum like this, what's really a more important limitation to think about is how this kind of study can inform public health policies. So obviously, you'd have to understand a lot more about the ethics of vaccine allocation than we've put into this model and the politics of it. We've clearly got evidence that the infections are not equitably distributed across our population. And in that situation, is it possible to use, to ethically use some consideration like network structure instead of some much more obvious consideration like need for a vaccine? I think it's a case where there's these intuitive policies, and if you want to propose something that's different from them, you really need some overwhelming evidence. And while a simulation study is pretty convincing to me, I have to respect people whose careers or lives really are on the spot saying, I think we have to give this vaccine to that person instead of that one, because I've been told that mathematically it's a better idea. We have to be able to present this in a way that really convinces people. And just along those lines, and I don't really know this story in detail, I just have a general picture of it, but in Japan in the 90s, there was a conscious decision made by public health authorities to vaccinate, to use their flu vaccine for children instead of seniors, because they had become convinced that that was the best way to protect seniors. So they weren't changing the cost function they were trying to optimize. They were just changing the path to get to the optimum. And it worked for years. And then one year they went back to vaccinating seniors, to prioritizing seniors. And I had the opportunity to ask somebody at one point in the Japanese CDC why they did that. And they said the problem was that the health minister woke up one day and there was a headline in the paper saying, seniors dying of influenza, but they're not being given the vaccine. And it was true. I mean, because they couldn't eliminate influenza and there were deaths, there was mortality in the senior population. But they were convinced, the people who were really working this policy were convinced that they had reduced the number of deaths, but they couldn't compete with the headline in the newspaper. So I think that's the real limitation of this policy. And we need to have some sort of discussion about how to deal with this problem. There are other things that are not necessarily modeling issues, but might affect the success of a policy like this. So it might turn out that vaccine uptake correlates with network structure. Just because you target something doesn't mean that that's where it gets delivered. But on the whole, I'd say it really seems worth it to start this discussion going again, because the strategy is so dominant, not just across outcomes, but across all the kinds of variables that we threw at this thing. And in particular, I think we've demonstrated that it's insensitive to errors in the way we categorize people, which should extend to errors in the social contact network that we've estimated itself. So I'll stop there and I think save time for questions.